Welcome back to the deep dive. We tackle a lot of complex topics on this show, everything from macroeconomics to history. But today we are zooming in on something very specific, very clinical, and honestly, something that strikes fear into the heart of almost every nursing student I've ever met.
It's the dreaded NG tube.
The nasogastric tube. Just saying the letters NG makes people wince. And it makes sense why. You're taking a fairly rigid plastic hose, inserting it blindly into someone's face, guiding it past their airway,
Which is a high-stakes neighborhood.
and just hoping it lands in the stomach.
It is invasive. There's no getting around that.
Yeah.
Patients hate it because it's uncomfortable, and nurses get anxious about it because the margin for error feels very, very significant. You're working blind.
Exactly. You cannot see where the tip of that tube is going. And that anxiety is what we want to dismantle today. We got a stack of clinical guides, procedure notes, and safety protocols here. And the mission is to turn this from a scary, blind procedure into a logical, controlled skill.
That's the right approach. When you strip away the emotion and just look at the anatomy and the physics of the equipment, it stops being a guessing game. It becomes a series of very specific safety checks.
So I'm going to play the role of the learner today. I'm the one standing at the bedside with the tube in my hand, hands shaking a little bit. I need you to be the senior instructor watching over my shoulder.
I can do that. And my focus is going to be on the why. Because if you just memorize the steps, insert here, tape there, you'll panic when something unusual happens. But if you understand the rationale, you can troubleshoot anything.
Okay, so let's start at square one. Why are we even doing this to people? What is the actual point of an NG tube?
If you look at the source material, the uses really fall into three main buckets. You've got lavage, decompression, and enteral nutrition.
Lavage sounds like something you'd pay extra for at a spa, but I know in this context, it is definitely not that.
Definitely not, no. Think of lavage as housekeeping or maybe cleaning the pipes. We use this when we need to wash something out of the stomach and fast. The most common scenarios are things like a GI bleed, where we need to flush out blood to see what's going on, or in cases of poisoning or medication overdose. We are actively putting fluid in and pulling it right back out.
So bucket one is emergency cleanup. Bucket two you call decompression. This is the one I feel like we see most often on surgical units.
Yes, decompression is all about pressure management. Imagine a patient who just had major abdominal surgery. Their bowel has gone to sleep. We call it an ileus. Peristalsis has just stopped.
But the stomach doesn't just stop working, does it?
No, and that's the problem. The stomach keeps making secretions. The patient keeps swallowing air. If the gut isn't moving things along, that gas and fluid just builds up. It's like inflating a balloon inside a fresh surgical site.
Oh, wow.
It causes distension, nausea, vomiting, all things that can tear sutures and cause aspiration.
So the tube is there to act as a relief valve.
Exactly. We hook it up to suction and pull that air and fluid out to keep the stomach flat until the bowel wakes back up.
And the third bucket is the inverse. Instead of taking things out, we are putting things in.
Enteral nutrition, feeding. This is for the patient who has a working gut. Their stomach and intestines can digest food just fine, but they can't swallow safely. Maybe they're on a ventilator or they've had a stroke. We use the tube to bypass the broken bridge.
The mouth and throat.
Right, and deliver fuel directly to the engine.
Okay, so cleanup, decompression, and feeding. Now, before we even touch the patient, we have to grab the right equipment. The notes highlight two specific types of tubes, the Levin tube and the Salem sump. Are these interchangeable?
No, and treating them as interchangeable is a rookie mistake. They have different architectures for different jobs. The Levin tube is the simple one. It's a single lumen.
Just a long straw.
Exactly, one tube, one hole. But the Salem sump, which is what you'll use for that decompression job we talked about, has a double lumen. It has the main clear tube for suction, but then it has this distinct, smaller blue tube attached to the side.
The famous blue pigtail.
The blue pigtail. Now, this is probably the most misunderstood piece of plastic in the hospital. I want you to understand the physics here. If you take a single straw, like a Levin tube, and hook it up to a vacuum, what happens when the glass is empty?
The straw sucks up against the side of the glass and gets stuck.
Right. It creates a seal. Now, imagine that inside a human body. If the tube sucks up against the stomach lining, it's going to cause what is essentially a massive hickey. It causes ulcers, bleeding,
Tissue damage.
serious tissue damage.
So the blue pigtail prevents that.
It's an air vent. It allows atmospheric air, just room air, to flow down that side channel. It breaks the vacuum seal so the tube floats freely in the stomach instead of eating the stomach wall.
That makes perfect sense. But here's the thing. I have seen nurses, even experienced ones, see a little bit of fluid creeping up that blue tube and they panic. They cap it off.
And that is a never event. The notes are emphatic about this. Never clamp the blue pigtail.
Because if you clamp it,
You have just disabled the safety mechanism. You've turned a Salem sump into a single lumen straw, and you are now putting the patient at risk for stomach injury. That blue port must be open to the air to work.
so if gastric juice is coming out of the vent, the answer isn't to plug it.
No. If it's leaking, it usually means the main tube is clogged or your suction is set too high. You fix the clog, you don't plug the vent.
Okay, that is a crucial takeaway. Don't touch the blue pigtail. Now, let's move to the bedside. I've got my tube, I've got my gloves, I'm walking into the room. Procedure guide says assessment first. What am I looking for?
You're looking for red flags. First, check the patient's level of consciousness. Can they follow commands? This procedure requires cooperation. If they're comatose or confused, it's exponentially harder and more dangerous.
And we need to check the nose itself, right?
Absolutely. You need to play detective.
Yeah.
Ask about nasal trauma. Have they had a broken nose?
No.
A deviated septum? Any nasal surgeries?
Why does surgery matter?
Well, specifically transsphenoidal surgery, where they access the pituitary gland through the nose. If you shove an NG tube into a patient who has had that surgery, there's a risk you could go through the surgical site
And into the brain.
and into the brain.
Okay, that is a terrifying mental image. Check for surgery history. Got it.
You also want to check patency. Have him close one nostril and breathe. Use the side that flows better. And check bowel sounds to establish a baseline.
Now, let's talk position. I feel like this is one of those things where doing it wrong sets you up for failure immediately.
You cannot do this with the patient lying flat. It's just physics. You want gravity on your side. High Fowler's position.
That means sitting straight up.
60 to 90 degrees. You want them sitting up as if they are eating breakfast.
Okay, patient is sitting up. I've picked my nostril. Now, the part that always stressed me out in labs, how deep do I go? People are different sizes. Eyeballing it seems reckless.
It is reckless. Do not eyeball it. We use the NEX measurement method. NEX.
Walk me through it.
You take the tip of the tube, place it at the tip of the patient's nose, then extend the tube to their earlobe. That gets you around the nasal curve. Then, from the earlobe, measure down to the xiphoid process.
That's the little bone at the bottom of the sternum.
Correct. Nose, earlobe, xiphoid. That distance roughly approximates the path to the stomach. Once you find that spot on the tube, you mark it. Use a piece of tape or marker. That is your goal line.
Okay, I've got my mark. I've lubricated the first 3 or 4 inches with water-soluble lube, not oil, because oil in the lungs causes pneumonia. I've curled the tube around my finger to soften it up. Now,
Insertion.
the moment of truth.
I start pushing it into the nostril. What if I hit a wall immediately?
Resistance is common. You're navigating tight spaces. The golden rule here is never force it. If you push against resistance, you can cause a nosebleed or, damage the turbinates.
So what do I do?
Rotate the tube gently, aim downward toward the ear. If it really won't go, pull back and try the other nostril. Okay, let's say I get past the nose. I feel it drop into the back of the throat, the oropharynx. The patient starts gagging, their eyes are watering. This is usually where the student freezes.
This is the turning point.
Yeah.
The tube is curling down the back of the throat. Gagging is natural. You need to pause. Give the patient a second to catch their breath. Do not just keep shoving.
And this is where the swallow technique comes in. This feels like the most critical part of the art of this procedure.
It is. This is where you stop being a technician and start being a coach. You need to instruct the patient to tuck their chin to their chest.
Why chin to chest? Instinct says to tilt your head back to open the throat.
That's true for CPR, but for an NG tube, looking up opens the trachea of the airway. We want the airway closed. Tucking the chin compresses the trachea and opens the esophagus in the back.
So chin down, and then we use water.
Hand them a cup of water with a straw. Tell them to take small sips. This is a coordination game. You say swallow.
Yeah.
When you see that thyroid cartilage move, you advance the tube. Swallow, push, swallow, push.
So the swallow actually pulls the tube down.
The swallow opens the upper esophageal sphincter. If you try to push when they aren't swallowing, the tube will just curl up in their mouth. You have to ride the wave of the swallow.
Now the scary question, how do I know I'm not sliding this tube directly into their lungs?
You have to watch the patient. If the tube enters the airway, the body will react violently. If they start coughing uncontrollably, if they can't speak, or if they start turning blue cyanosis, you are in the airway.
And if that happens,
Pull back immediately. Not all the way out, but just pull back until the coughing stops. Let them recover, then try again with the chin tuck.
okay, Let's say the coughing didn't happen, the swallows worked, I've advanced all the way to my tape mark, I tape it to the nose, I'm done, right? I can hook up the feeding bag.
Absolutely not. Stop right there. This is the most dangerous assumption you can make. Just because the tube is into the mark doesn't mean the tip is in the stomach.
It could be curled in the esophagus.
Or it could be sitting in the bottom of the lung and the patient just didn't cough much because they have a weak gag reflex. You have to verify.
The notes call this the gold standard.
The gold standard is a chest x-ray, period. You cannot use that tube for anything. No meds, no food, no fluid, until a radiologist looks at a picture and says, yes, that is in the stomach.
Is X-ray mandatory every single time?
For the initial insertion, yes. Every time.
Okay, but what about pH strips? I remember learning about testing the acidity of the fluid.
pH testing is a great tool, but it is a secondary check. It's for maintenance. Once the x-ray confirms placement, you can use pH to recheck it later in the week.
And what are we looking for with pH?
You aspirate some fluid with a syringe. You want it to be acidic, pH of 5.5 or less. That tells you you're in the acid bath of the stomach.
What if it's high, like 7 or 8?
That's alkaline. That could mean you're in the intestine, or worse, the lung. Pleural fluid is alkaline. So if you get a high pH reading, hold everything and investigate.
Got it. X-ray is the judge and jury.
Okay, x-ray confirmed. We are live. Now let's talk maintenance. These tubes can clog up, right? Constantly. Especially if you're putting crushed pills down them. We have to irrigate to keep them patent.
The outline specifies using isotonic saline for this. Why not just tap water?
It comes back to physiology. Tap water is hypotonic. So if you keep flushing a patient's stomach with plain water, eventually you can cause electrolyte shifts. Normal saline matches the body's fluids. It's just safer for the patient's chemistry.
And there's a math note here that I think trips people up. Subtract the saline from the total output?
Yes. This is vital for accurate charting. Let's say I push 30 cc's of saline into the tube to flush it. Then I hook it back to suction. An hour later, I empty the canister, and there is 100 cc's of fluid.
The patient didn't actually lose 100 cc's.
Correct. 30 cc's of that was the saline you just put in. The patient's true gastric output is only 70 cc's. If you don't do that math, you're recording false data.
Okay, let's shift gears to the feeding bucket. We've established the tube is in the right place. We are starting enteral nutrition. What are the safety rules here?
Gravity is the big one. You simply cannot feed a patient who is lying flat.
Why is that?
If you fill the stomach with liquid while the patient is supine, it can easily reflux up the esophagus and spill into the trachea. That causes aspiration pneumonia, which is often fatal in these patients.
So what's the angle?
Head of bed HOB must be elevated at least 30 to 45 degrees during the feeding and for 1 hour after.
It's basically the don't lie down after a big meal rule, but stricter.
Much stricter.
Now, how do we know if they're actually digesting the food? We're pumping it in, but what if the stomach isn't emptying?
That brings us to gastric residual volume, or GRV. This is the check the tank moment.
So every few hours, we check.
Right. Every 4 hours for continuous feeding or before every bolus meal, you attach a large syringe and gently pull back to see how much fluid is sitting in the stomach.
And if I pull back a huge amount, that's a red flag.
It means they aren't digesting. The source material gives us specific limits. If you get more than 500 milliliters at a single check, you hold the feeding. That's half a liter of fluid just sitting there.
Or if you get high amounts consistently.
Right. If you get more than 250 milliliters, 2 checks in a row, an hour apart, you also hold the feeding.
Now, here's the part that I think grosses people out the most. I have just pulled out 200 milliliters of gastric contents into a syringe to measure it. What do I do with it? Do I throw it away?
No. You put it back.
I put it back.
You return the residual. That fluid isn't just waste. It is packed with electrolytes, gastric enzymes, and the nutrients we just gave them. If you throw away 200 milliliters of stomach contents every 4 hours, you're going to throw that patient into metabolic alkalosis and wreck their electrolyte balance.
So measure it, record it, and gently push it back in.
Exactly. Return the residual.
Okay. Last big topic, medications. We have a patient with an NG tube. They have pills due. We can't just have them swallow.
And you can't just crush everything willy-nilly. First step. Check with the pharmacist. Is this pill crushable?
What wouldn't be crushable?
Anything that says extended release or enteric coated. If you crush a slow-release blood pressure med, you might dump 24 hours worth of drug into their system in 5 minutes. That can be very dangerous.
Okay, assuming the pharmacist says it's safe.
You crush it into a fine powder and mix it with about 20 milliliters of water. You need it to be liquid.
And the sequence.
It's a sandwich. Fush, med, flush.
Explain the sandwich.
First, if they're on a continuous feeding pump, hit pause.
Mm.
Stop the food. You don't want to mix meds and formula in the tube. It can clump up.
Good point.
Then check your placement and residual. Then flush with about 15 to 30 milliliters of water. This cleans the road. Then pour in your dissolved medication, let it flow in by gravity. Then flush again with water.
The second flush is to make sure the med actually gets into the stomach.
Right. You don't want the dose coating the inside of the plastic tube. You want it in the patient. And then, this is the step everyone forgets, turn the feeding pump back on.
That feels like a classic oops moment. Walking away with the pump paused.
It happens all the time. Always double check before you leave the room.
We have covered the entire life cycle of this tube. Insertion, verification, maintenance, feeding, meds. Eventually the patient gets better. The tube needs to come out. Is removal just yank and pray?
Please don't do that. It's definitely faster than insertion, but there is a technique to doing it cleanly.
What's the prep?
First, flush the tube with 30 cc's of air.
Air. Why air?
You want to clear any acid or formula out of the tube and push it back into the stomach. If the tube is full of liquid, you pull it out. It can drip fluid into the airway as it passes the throat.
That makes total sense. So blow the line clear.
Then instruct the patient to take a deep breath and hold it.
Why holding the breath?
When you hold your breath, your glottis closes. It seals off the trachea. So while they are holding that breath, you pull the tube out steadily and smoothly. If any drops do fall off the tip, they hit the closed glottis, not the lungs.
And then hand them a tissue.
A tissue and some oral care. Their mouth is going to taste terrible, but usually they are just so happy to have that thing out of their nose.
Wow. We really did just break down one of the most intimidating skills in nursing.
It's a lot of steps, but they all connect back to safety.
So as we sign off, let's recap the never events. What are the absolute hard lines our listeners need to remember?
1. Never clamp the blue pigtail on a Salem sump. 2. Never force the tube against resistance during insertion. And 3. Never use a newly inserted tube without X-ray confirmation.
Solid rules. And looking at this whole process, what stands out to me is the balance.
The balance of art and science.
Exactly. The science is the pH, the suction physics, the NEX measurement, but the art is coaching a terrified patient through a swallow. It's the ability to be the calmest person in the room when you are shoving a tube down someone's throat.
That's what makes a professional. The technical skill gets the tube in, the empathy gets the patient through it.
A great place to leave it. Thank you so much for walking us through this.
Anytime.
And to our listeners, remember that policies vary. Always check your specific facility's manual before you do this. Stay curious, stay safe, and we'll see you on the next deep dive.